Hey guys, it's Nurse Gwenny. Let's talk about disseminated intravascular coagulation, or just DIC as we call it for short. So disseminated meaning it's happening in the entire body, intravascular meaning it's happening in the vessels or in the vasculature, coagulation, making a whole bunch of clots. So our patients never just happen upon DIC on their own. It's usually in our patients who are super duper sick, critically ill patients. The number one precursor to DIC is severe sepsis. It can also happen in our severe trauma and burn patients. It can happen in advanced metastatic disease, meaning really bad cancer, and maybe a half dozen other things, but mostly we see it in our septic patients. As a matter of fact, in my decade of doing this, I've only ever seen it in one patient, and it was somebody who had severe sepsis. And then he was an elderly patient with urosepsis, and we all know how they act. They're kind of like a little bit bonkers and somewhat aggressive. But he pulled out his Foley, fully inflated, and it was the straw that broke the camel's back. And what happens in DIC, disseminated intravascular coagulation, is it's kind of like, I like to think of, have you seen Inside Out 2? Anxiety, the new character? Yeah, I imagine her just like slamming down the panic button and the whole body just freaks out, and it activates this inflammatory trigger of the clotting cascade, and our body just starts forming clots everywhere. As a matter of fact, I like the European word for DIC better than the American word. They call it consumptive coagulopathy. Consumpting meaning we've consumed all of our clotting factors. And so we have these microvascular occlusions that prevent perfusion, and those kind of team up and join together to form macrovascular occlusions, and then we just have poor perfusion everywhere. And then because we've used up all of our platelets and clotting factors, we start bleeding from the everything. Now, if you're taking your NCLEX or your CFRN or any kind of exam, they might ask you, what are the lab values that you're going to see in DIC? Well, yes, if you have time to grab some labs, you're of course going to see low platelet count, because they've all been used up, and a high PT, meaning it's going to take a long time for your blood to clot. But in real life, you don't have time for labs. There will be clinical signs called the patient is bleeding from their nose, their eyes, their ears, every IV site or any kind of venipuncture site that's been hit in the last couple of days. My patient was also bleeding from his meatus. They bleed from the everywhere. Managing these patients is exceptionally difficult, and the mortality rate is super duper high. We usually don't have a good number, like it's not, I can't tell you it's like 90%, because we don't know what killed the patients, the DIC or the severe sepsis or the advanced metastatic disease or these severe trauma and burns. So as I said, it's in these severe critically ill patients. So managing these patients, number one, treat that primary pathology, whether it's the sepsis, the trauma and burns, what have you. But also we have to transfuse a lot of these patients with plasma and platelets. Obviously they need platelets to clot, but they also need plasma because plasma is where all of our clotting factors are, except those platelets. So now you know a little bit about this disseminated intravascular coagulation, or the name that I like for it a little bit better is consumptive coagulopathy.